Hi, everybody. Welcome back. Right now, we're going to be talking about introduction to documentation. So we've talked a little bit about goals and objectives in APIDE. So now we're going to go a little bit more in depth into an intro on different documentation processes, things that you should do and shouldn't do when it comes to documentation, and all that fun stuff. So here we go. So typically in healthcare, we use electronic documentation, and typically that'll be referred to as an EMR, an electronic medical record. So it's a collection of health information which is generated by one or more meetings in any care delivery setting. And an electronic health record, an EHR, is the same thing. So that's typically what you will see when you're in different levels of healthcare, whether that's a skilled nursing facility, whether it's a hospital. Community recreation can be a little bit different in terms of documentation. Mental health, also, I have worked in facilities where we actually do paper charting, which is a kind of a pain in the butt. Everything's on paper and it gets recorded in binders and physically put in the chart. But for the most part, we are using an electronic medical record in most settings today. So here are some of the benefits of electronic documentation. They include more accurate records. So typically something will tell you if there's like a typo or something like that, or if you need to add something, or won't let you proceed if you haven't added a certain block. The legibility, CMS, that's recording 10.7% of improper claims, and this requires all accurate entry. The real-time access is also improved. So there's, like I mentioned before, there's no fighting for the chart. So, for example, when I worked in mental health, there was a lot of times where I would have notes ready to go and nursing had it, or the psychologist had it, or the social worker had it. So it was actually really frustrating to have to wait on that binder or that patient's physical chart to put their notes in there. And also you can, open it up in multiple different sites. A lot of people can have it open at one time, so that's also what makes electronic documentation a lot better than paper charting. So this also allows identification of the healthcare providers to be involved in patient care. It allows the sharing of medical files between disciplines across the field, and the billing and patient care is also expedited. So for insurance purposes, for CMS, other insurers, having the electronic medical record makes it a lot more seamless with all of that transition. So there are some criticisms of electronic documentation, even though, like I said, for the most part, it's much easier than paper. It is legible sometimes, but not decipherable. So you have to sometimes click through the systems, and that can make it less professional and interpretable to some people that might be looking at the chart. Not all quick systems fit healthcare patients to their individual treatment plans, and they might not have a pull-down menu. Also, sometimes different electronic medical records systems might not be appropriate for a setting, even if your agency uses it. So just as an example, when I was working in the adult daycare setting, we used an EMR that was really meant for hospice patients. It wasn't so much meant for adult daycare. So I really had to do a lot of tweaking when it came to writing the goals or choosing a goal from the drop-down menu or creating a care plan, even because it wasn't meant for adult day. It was more meant for hospice or skilled nursing. So sometimes it's not one size fits all, which can make it a little bit challenging. It can also be difficult to emphasize data and notes for early access, and also training time. So it can take a little bit longer when you're learning a new job. It can take longer to get in the groove of using an EMR, figuring out where everything is, where you need to put everything to make sure that everything is documented accurately. Some other things to consider are the vulnerability. So if the computer crashes, or if there's like a cyber attack on your hospital, that's obviously something, very scary, but also very real today. So I know that there is a hospital I used to work at that did get hacked. We had to go to all paper charting for that day. So at least knowing how to do that, looking at secure data. Also keeping in mind medical fraud and overbilling, and the fact that each step of the process can take multiple minutes, 2 to 5 minutes, just navigating around and making sure that everything gets put in the proper places can be a little bit time consuming as well. So template documentation. So a lot of electronic medical records systems will supply kind of preset responses for the process, kind of like I was talking about earlier with the system that I used to use when I worked in adult daycare. So they'll have kind of templates that you can just copy and paste, or SOAP note templates, or different flexible agency templates. So that a lot of times will have like a drop down menu for goals, and you can input the goal, and then from the goal that you select, it'll automatically populate some objectives, so you can kind of plug and play, which definitely is nice and makes it a lot easier when you are writing your goals and objectives, so you're not having to come up with everything from scratch, especially in certain settings. A lot of goals are similar. For example, an adult day, just going back to that one really quick, is a lot of times my goal would just be to decrease isolation due to non-participation in recreation programming, or to increase level of sociability, so that, you know, you can put that in there and then find the appropriate goals and the objectives to match that goal. So this is just looking at an EMR example. Again, they're all different, but you can kind of see it's showing you different. A lot of times all of them will have a patient profile, have notes that you can see from the other disciplines, the assessments that were conducted by other disciplines, whether that be doctors or other therapists, and then the treatment plan. So again, this is just an example. They're all a little bit different. This actually one doesn't look like any that I have used in the past, but they're all different, all a little bit different to navigate. And again, this is just kind of more template. It kind of helps you, give you an idea of what that might look like for the participant with their needs. So moving along, we're going to talk about types of charts and progress note documentation. So there are different documentation formats. So healthcare monitoring systems. So that might include just the vital signs. So that's weight, pain, BP, heart rate, appetite. That is typically going to be done by nursing, skilled nursing. Not typically something that we are focusing on a regular basis, but also something that we should be able to have access to within the EMR when it comes to doing your treatment or intervention with a participant on that given day. And then there's also going to be documentation of ongoing treatment. So those are typically treatment notes. So that would be typically where rec therapists or other therapists would be putting their notes. So that's like where RT, OT, PT, speech, child life, social worker, whatever other disciplines are where you're working would go in those ongoing treatment note sections. So the three general documentation methods are problem-oriented record keeping, source-oriented record keeping, and narrative format. So the problem-oriented medical records that was introduced by Dr. Lawrence Weed, POMR as it's abbreviated. This includes database or initial assessment. It includes a client problem list, an initial treatment plan, progress notes, and a discharge summary. So a SOAP note, S-O-A-P, which we're going to talk about later in the semester, is often used in this method. So the problem-oriented record keeping. So yeah, for example, SOAP notes are the oldest, and they're the most widely accepted general form of POMR progress notes. They are source-oriented medical records. The information is often categorized by different disciplines, and it's a way of organizing the information into the client chart that is effective. So the narrative format is going to be a chart in chronological order of the events that happen, including gathering the information for that particular participant or patient. It's a sentence structure, and it's usually preferred. So I've typically done a lot of narrative notes in the hospital setting, so writing a note, typically 3 to 5 sentences of the treatment and what I did with that patient on that particular day. It is time consuming. I can tell you that typically after treating my patients, like in the hospital, for example, I would go back to my computer and it would typically take like about half the day. If I saw anywhere from 5 to 7 participants, it's time consuming just because you need to make sure that it's legible and you need to make sure that the notes are detailed, but also easy enough to be understood by whoever's reading them. So not having like crazy words in there, and making it so that if any person was looking at it, or say you had to there's litigation or anything like that, anyone could pick it up and understand what they were reading and what you were talking about. So other types of documentation systems: critical pathways or healthcare maps, SOAP notes, as we talked about a little bit, which we'll touch on more, PI, flow sheets, focus charting, and charting by exception, or CBE, are other forms, and we're going to talk about a lot of those throughout the semester as we get further into things. And moving on to the last section, we're going to talk about some do's and don'ts of documentation. So documentation is a form of communication. It's a legal document, and it's a document of service. So these are all things important to keep in mind when you are documenting in any setting. It's a form of communication. Good documentation is promoting the continuity of care through clear communication between all members that are involved in patient care. The medical record is a way to communicate treatment plans to other providers regarding your patient. So this is ultimately meaning that the patient is going to receive the highest quality of patient care. And on the flip side of that, poor records can have negative impacts on the clinical decision making and delivery of care. So that's really important to keep in mind, that whatever you're writing is crucial to their care, but then also, again, needs to be ethical and legible and all of that. It's also a legal document. So a medical record is a legal document. So knowing what you write in case it is questioned or litigated against, or there's any legal proceedings, it can be heavily scrutinized. So it's really important to help support the document in any way. And documenting sensitive discussions regarding limits of care and the prognosis and transparency is crucial. So we'll talk about that more again throughout the semester. And finally, it's a document of service, which means this is a point that can be missed when we're just in the groove of things documenting. Medical documentation is a document that has really big implications for hospital funding. So each issue that is documented is coded and then translated into a cost for the hospital system. So whatever you're writing and coded against is super important to keep in mind. Documentation of all medical issues and treatments is crucial for hospital funding, particularly in those discharge summaries. So discharge summaries can impact insurance and coverage and all of that. So that's another fun, important thing to keep in mind when it comes to documentation. So a few do's and don'ts to avoid potential mistakes are going to be covered over these next few slides when it does come to documentation. So the first do is to date, time, and sign every entry. This will typically be prompted, whatever EMR especially you use, there'll typically be a place for date and time. And it's a simple thing, but it's super important. Timing of events is crucial for piecing together information with deteriorating patients, or to be able to see if there is a significant change with a particular patient. And making entries as immediately or as soon as possible after the care is given. So typically, if you're able to, when it's fresh, I like to go back and document, or I would take, if I was in the hospital and did a session with a particular patient, I would do my session and then have my laptop with me, sit at the nurse's station for a few minutes and do, write everything out as it happened, just so it's all fresh in your mind. And that's something that's really important because you tend to forget. If that isn't possible, carry a notebook. So if you are seeing like patients back to back, I would often carry a notebook with me and just say, put the date and the time that I saw that individual patient. And then I would write down what I did with them. So the basic notes, with whether it be related to play or what positions that they were in, or all about if it was a co-treatment or not. So writing down specific notes so that you are then able to go back and write an effective note as promptly as possible. The prompt documentation can reduce the risk of forgetting any key details. It also ensures that all team members are aware of any changes to a patient's condition or their care plan. So it's not always possible, like I said, like lots of times you're running on patients back to back, but having a backup plan, having either a notebook or some other way for you to remember what happened in the session is really important. Also maintaining a professional tone, obviously, should go without saying, but sarcasm or attempted joking, a casual tone in a note is generally frowned upon. Making sure that you maintain professional language throughout your documentation in whatever form that may be. Another do is before entering anything, you're going to ensure that the correct chart is being used. So again, that seems simple, but when you're working, especially with multiple patients, making sure to check, double check, and triple check the patient, his correct name, date of birth, and you're charting in the right chart. Include the most current information of their session, including any pertinent clinical information. So if anything crazy happens during the session or any crazy change, noting that. And again, always using complete descriptions throughout your documentation. Do. So record if the patient or participant refuses treatment. So sometimes that does happen, especially in a skilled rehab type setting. So you always have to attempt, but definitely document that. So if you come into a room, somebody's sitting down and say, "Hi, I'm your recreation therapist. I'm here to do X." And they say, "I'm not in the mood," or whatever it may be, making sure that you indicate that they refuse treatment. Again, with the day and time, if you're able to go back later and follow up with them, say followed up again at this day and time, etc., just to have that documented so it doesn't look like you just didn't see that particular person. Again, charting at the time that you provide treatment. It's easy to forget details, so again, chart when it's fresh in your brain. You can go back and add a late entry for information that you forget during charting, or if you, for whatever reason, forgot to chart on a particular patient on a particular day. Typically, you are able to put it in a system, and that will again vary from whatever organization you're working with in terms of how far back you can actually chart a late entry, whether it's 24, 48 hours. Typically, it's not any more than 72 hours, but making sure that you go back, clicking it and writing late entry and then the date that the service actually occurred is important. You're always going to document often enough and with enough detail to tell the whole story of how the client is doing, how they're meeting their goals, etc. And then you're going to always include some follow-up plans in your notes as well. So write legibly. So again, if it is a paper chart, that's all you have to go off of. There's no electronic charting that you're going to be looking at. So making sure to be legible in your writing so that people can actually read what you're trying to say. I know a lot of times doctors are known for having chicken scratch, but really try your best to be neat. These are two examples of a do and do not do, don't do in terms of how a written note should look. So some don'ts, a lot of them are probably pretty self-explanatory, but we're just going to run through them really quickly. Do not alter a patient's record, so that is a criminal offense. So never change anything of any way in a patient's record unless obviously you've talked to your administrator about it, your doctor, whoever you're working with. Don't use shorthand or abbreviations that aren't widely accepted. There are certain abbreviations that you'll see often depending upon what setting you're in. For example, like I said before, PT is often patient, ROM, range of movement, things like that. There are certain things that are accepted, but don't just have abbreviations for the sake of having abbreviations. And if you do put them in there, make sure that they're relevant and that it's easy to follow. You're also never going to chart when someone else said, heard, felt, or experienced unless the information is critical. Use quotations if possible, but in general, we're not going to chart on how they're heard or felt or something that they experienced. You're never going to chart care ahead of time, so you can't really chart on something that didn't already happen. So even if you think that you might know how a session is going to go, you really can't say 100% how it's going to go in terms of their mood or what they were able to accomplish that day. So when patients are in care, their situations are ever changing and ever fluid. So don't chart or document on anything unless the care is actually performed. So again, we're going to want to be aware of words that will never hold up in court. So avoid labeling words like demanding, grumpy, lazy, crazy, bad attitude. Describe actions and quote in their comments. You're going to want to avoid words that exaggerate and words that embellish or inflate, like always and never. Just avoiding that uncertainty is helpful in that you don't want to do anything that can potentially get you in trouble in court. So for example, you're not going to write this. Patient is non-compliant about checking his blood glucose levels at home. Write something like, patient reports he did not check his blood glucose levels at home today or yesterday. Patient reports the last time he checked his blood glucose level was 2 months ago on 10/1. So you're being specific was when the action last happened. You're not being accusatory. You're not saying they're non-compliant. You're just simply stating the facts. Again, with written notes, we're not going to scratch out information. So if you have to make a correction to a written note, don't just scribble over it. You're going to cross it out. Typically, you'll initial it or sign it and date it next to it. Don't just cross it out. That can look suspicious sometimes if there is any litigation or anything like that. Make sure that you deliberately cross it out and indicate that there was an error in your notes documentation written-wise. Again, you're going to want to avoid words like suffers, battling, inflicted, seems, appears to be, demanding, grumpy, and irritating, fair, normal. Just being clear and concise. Not all of these words can kind of be up to interpretation. So being clear and concise with your documentation. And then kind of the so some of these things could be a little bit confusing, if that's all you write. So patient was alert and unresponsive. What does that mean? Patient has chest pain if she lies on her left side for over a year. The skin was moist and dry. So those are conflicting things. So the skin was moist and dry. So obviously that can't be, if your skin's moist, it's not dry. Again, patient was alert and unresponsive. If you're alert, you're responsive. You're not unresponsive. So things to keep in mind. Just making sure that your verbiage lines up. So patient has done well without oxygen for the past year. So that's probably not true. That's pretty talented, if they haven't breathed for over a year. So just making sure that you are really making sure that you make sense with what you're saying and what you're writing, and that everything tracks and goes together, not just writing words for the sake of writing words. And then conversational and informal notes versus a professional and formal note. These are just a couple examples. I'll let you go ahead and read those on your own. But in general, we want to have a more professional and formal tone when we're writing our notes and documenting all of that. So you can read the differences there. And that is the lesson for today. Thank you all again for tuning in. And if you have any questions, as always, feel free to reach out and let me know. Have a great week, everybody. Bye.